Hello guys, how are you all? Thank you so much for joining our today's session. So today we are going to have a free role play session for everyone. And as you know that the AMC clinical exam has been changed a lot, right? So now you have to do physical examination from online. So in one way, it's good that it's only you have to just talk about what you are going to do. You don't need to find anything because previously when we appeared the exam, we have to do it on the patient. And trust me, it was really terrible because we have to be really careful about the findings, about whatever we are doing. Even just a slight touching the patient can fail us because if we could not say that I'm going to touch your arm or I'm going to do this physical exam, if we don't do that, they would fail immediately. So it's good in a way that those things are not there at all. Now, what they're asking you mainly in physical examination, that you need to explain physical exam to the role player or maybe to the medical student or even to an intern. Okay, so that's mainly the changes. As you understand by the look of my talking, that today we are going to do mainly the physical examination role play. And trust me, like this is the first time I'm doing physical exam role play because previously it was not possible. So as you can see, this is a new era of online physical exam role play. So we have to adapt with whatever comes along our way. As you can see in here, this is exactly what will look like in your exam. So let's say that you enter into the Zoom room and or the exam room. The exam room will be looking like this. So there will be a screen on your left hand side, and in your right hand side you can find out your your image. So this will be your video. You can, when the exam starts, like your 8 minute time inside starts, then you will be able to see the role player sometimes if the task permits. So that's the role player. This will be the invigilator. Sometimes you will be able to see invigilator, especially when you enter into the room in the outside 2 minutes time. An examiner will not be visible at any point of your exam. Okay, so that's the 4 persons in the Zoom room during your exam. Okay, and also the other participants, you will be able to look at them like when you start your exam and also in between your exam sometimes. So I want to start with a role play first, just to see that how you guys think that you need to do the physical exam, because I can see many of you are already my course students. So you guys already know that how to do role play, how to do physical exam. I can see that some of you are from like our previous batch also, which we already covered everything. But unfortunately, this online role play you guys online physical examination you guys has missed, right? So because we did not know at that time. So now this is a new thing, and don't worry, like the course students will be will get all our new physical examinations, which we are going to do with the recent batch. Okay, so that should be fine. I'll add you to our physical exam classes. Now let's start with a role play. See that how you guys are doing role play, and then I will show you what is the exact way to do that and how you can get like maximum marks from this online physical examination. Remember one thing, to pass AMC clinical in the first attempt, you need to have a very good idea on physical exam, because most of you will get at least 3 or 4 physical exam on exam. So it's a vital part for your exam, not even online, even in face-to-face exam, physical examination parts a major role in passing this exam. Okay, so it's really important. If you guys don't understand anything, if you guys have any questions, which I guess you have a lot at the moment, feel free to ask me. I will try my best to answer your queries. as per as I know about the process, because this is still a new process, right? Just I have seen like March and April exam has been going on only. So it's still new things. They are introducing new things every day in the exam. So it will be a new process, but as per I understand, as per I know about the exam process, I will try my best to answer your queries. So as you can see, I kept two of the most important role play for this year, as per I can see from March and April. So rash physical examination is very important. A lot of rash differential diagnosis are coming, like you can get any of the rash physical exams. So important is like ITP, HSP, sometimes even rash due to giving antibiotic in a patient with Epstein-Barr virus infection. So these are all very important cases. There are also lots of cases related to rash, which we will discuss today. And rash physical exam is exactly related to hematological exam. All right. So if you want to do role play, I would say come to the Zoom. I can see there is a lot of people in the Facebook Live. So if you want to do role play, please come on the Zoom. Zoom ID and password is already given. Just insert that and you will be able to join here, because I can't do role play on the Facebook. Okay. All right. So who wants to do the role play? I can see Dr. Najia has expressed. Okay. So I will start with Dr. Najia. I will unmute you and just let me know that if you can hear me.
Unmute. Yeah. Just a second. I'm just one. Okay. Yeah. Please.
All right. So as always, the timing will be 2 minutes outside and
yes,
8 minutes inside. For the physical examination, I'm going to give you 8 minutes just because this is totally new things. But normally when you will be doing role play with your partner, keep it 1 minute outside and 7 minutes inside. Okay. So that's your case. Your 1 minute, your 2 minute time is started. All right. So, hi, doctor. Can I check your ID, please?
Yeah, this is my ID.
Okay, so this is your patient father is here. The father name is David and the child name is John. You can start.
Okay, hello, I'm Dr. Nazia. From the notes, I can see that John has some rash on his body after having some antibiotic penicillin. I'm very sorry to hear about this. So regarding this issue, I need to examine John. In this examination, it will involve having a close look at the rash and different parts, and then feeling the rashes and other parts of the body and do some tests. Would that be okay with you?
Yes, doctor.
Okay. Okay, and first, on general appearance, I can see the John is sitting comfortably, no distress, no sign of no cough, no sign of any respiratory distress, or no. Okay, then first I need to examine the rashes. So on the in the whole body. Okay, first I can start from the pulse and blood pressure. So I would like to know the pulse and blood pressure of my patient. Pulse rate rhythm. Okay. Then first on the hand, okay, John, could you please bring your hand? Yeah, John, is there no spoon-shaped nail, no brittle nail, and no pallor, and no skin color changes, no yellow, any skin discoloration, and no pale nail beds. And I want to see on hand any palmar creases. That is there any anemia, or then I want to okay, there is overlaying skin. I need to check is there any petechiae, purpura, or bruises. Okay. So first checking is there a anemia or any nail changes, like spoon-shaped nail, koilonychia means whitish the nail. Okay, and I would like to check the pulse and blood pressure, and is there any rate rhythm? Okay, that. I need to go to the John's face, and then I'm checking eyes. The lower part of the this we call conjunctiva. Is there any pallor in the eyes, or any in the white part of the eyes? Is there any yellowish discoloration? Then with the an overall face, is the color of the face or any rash? Then open. I need to open John's. Oh, John, can you please open your mouth? Okay, with the pen touch and tongue depressor, I'm going to touch this in your tongue. Okay, I'm checking is there any oral mucosal pallor, any angular stomatitis. Means we are checking anything in the corner of the mouth, and then any tonsil enlargement, any redness. Okay, and any gum bleeding, any gum bleeding, gum infection, or gum swollen, anything. And then after mouth, I need to check the John's lymph node. Okay, so first I'm checking is a lymph node in the elbow. So first I'm placing my right hand on the John's right elbow, and then I'm feeling in the elbow. Is there any, we call it epitrochlear lymph node. Is there any, is it enlarged or not? Okay, then I'm going to behind the John to check neck lymph nodes. There are some groups that is we call, so I'm checking the cervical, we call cervical lymph nodes. There are many lymph nodes in the neck. Okay, then after that, I need to check some lymph nodes in the armpit region, we call axillary lymph node. So I'm checking, there are 5 groups of lymph nodes. I'm checking all of this. So we are usually checking size, shape, any tenderness, increased temperature, is it mobile or not.
Lymph nodes, doctor?
Lymph nodes is our some glands there. And is it usually in infection or anything? These glands are our part of immune system, and it is sometimes infectious or swelled up. Okay, after this, then checking the, okay, David, now I want to move the John's tummy. I'm feeling some organ like liver and spleen. Then, okay, John, can you please take a deep breath? And okay, I'm gonna sit at the level of the bed and start palpating the liver. Can you please take a deep breath? Okay, then after I'm checking is there any liver enlargement, then I'm going to start from tummy at the corner of the tummy. We call it right fossa. And so it is in the spleen. I'm checking. Okay, and then after that, I want to check. I want to check, is there any, I want to check, then there is some groin area, there is some lymph node. I want to check this as well. It is called the femoral lymph nodes. I want to check this. And then I want to, now David, I want to check some tenderness in the John's bones, like this is in the in the anterior chest, it's called sternum, and this is our collarbone here. Okay. Is there any tenderness over there, and spine as well? Then I want to check in the lower limb, the skin color condition, any ulcer, any petechiae bruise after that. Okay, and then now okay, thank you, John. I want to talk with the examiner. Okay, hello examiner, can I have a description of the rash? And where I want to know what is the site and site extension of the rash. Is it blanchable or not? Is it raised or not? Any tenderness and any local temperature rises? Hello?
The examiner is not supposed to talk.
So, then the findings? Oh, okay. So what findings you are looking for the examiner? Okay, for the rash examination, I want to know, for the rash examination, for the rash examination, I want to know what is the site, size, shape, extension of the rash. On inspection, I'm looking this, and on the palpation, is it blanchable or not, in raised or not, any temperature, is it tender or not, is it cord-like or not? These findings, and I want to do that and a thorough skin survey. Is there anywhere else the rash is spreading or not? Yeah, and yes, and from history and examination, most likely it is antibiotic induced rash, as because penicillin sometimes can cause rash. So so my diagnosis is it is antibiotic induced rash.
Thank you, Dr. All right, Dr. Najia. So that's what I wanted to see actually, like what's the level of understanding the new changes of physical exam. It's, as you can see, Dr. Najia, so it's not like it's easy, but if we don't know what they're actually asking, like what's the matter going on over there, we need to understand that. So as I said initially, that examiner will not talk to you. He will be there, he will assess you whatever you are doing. You cannot even see the examiner. Okay, so examiner will not answer anything whatever you say, like I just answered you because I knew that you did not know about it. So but in the exam, like if you just ask 100 times to the examiner the finding, they're not going to talk to you. So please make sure that you know about that. The task is very clear cut, like tell what finding you are looking for to the examiner. That's one thing. Previously, when examiner was giving us the information, then usually ask physical examination findings from examiner. That was a different thing. So PEFE was physical examination finding from examiner. If that is written in your task, then examiner will talk to you because examiner is supposed to give you the finding. In here, that they have changed the thing. So now the examiner will not give you any finding. Tell what finding you are looking for to the examiner. So you will just tell that what you are looking for. Now, I know that what's going on in most of your head, that how I'm supposed to know the diagnosis if I don't know any finding, right? The thing is, in here, most of the time, the stem will be very clear cut of the diagnosis. So if it is an ITP case, they will give you something like that, like a 5-year-old child recently had a viral flu-like illness, now start to have this kind of rash in the legs, which is kind of purpuric rash. So they will give you something like that to know the diagnosis. So you will just diagnose based on that. Now
Okay.
in here, looking at the question, you know that patient had a sore throat and you have given penicillin. Now patient having rash. That is exactly what we known as EVV rash, right? So this is how we are going to say our diagnosis. Now, sometimes I have
EVV rash or
heard
antibiotic induced rash?
that's mainly like, yes, like antibiotic induced rash. Now in here, we have to say that it's like the explanation I will tell you that how you can explain. It's not like if we say antibiotic induced rash, it seems like it's the patient is allergic to this antibiotic. The rash patient has after taking the antibiotics in a patient with EVV is not allergic rash. It's a kind of immune mediated rash. Okay, so some kind of idiosyncratic rash. So we cannot just say antibiotic induced rash. The explanation will be a little bit of different than others. I will just discuss about it, that how to explain the diagnosis in here. That means you have to talk about both. You have to say EVV, you have to say antibiotic, both. Your diagnosis should include the both term. I'll discuss that later on. So that's the thing. Now, I'll just mute you, Dr. Najia,
Yeah.
for the purpose. Let me explain that how we can do this physical examination. One of the important thing in here that look at these two tasks. One is that tell the patient's father what step you are going to do. They're asking that what are the step? The step means you don't need to discuss the physical examination with the father. That means you don't need to say that I'm going to, like, I'm looking for koilonychia, leukonychia, clubbing. Patient doesn't understand anything that you are saying. And that's not your task also. What you need to do, you are just going to say the steps. So steps means that you talked about wipe approach. That means you introduced, you did all the initial thing. When you come to the examination, your step means just the headline of the examination that you are doing. So headline means general appearance, hand, rash, face, ear, nose, throat. So these are the headlines of your examination. You are just saying to the father that this is the step that you're going to do. And then when you go into the step, the findings that you are looking for, you will say it to the examiner. That means you are going to finish this both tasks in one go. In that way, it will be comprehensive and it will be a very good station rather than just saying one time that how Dr. Najia did. So you told all the things to the patient's father at one time, and then again you just did it same things with the examiner. So this is not actually what they're asking for. Okay, let me tell you that how we are going to do that. Now, most of you who are part of our course, First Aid AMC Clinical, you guys already know the hematological exam. The exam remains same, but the way or approach of doing the physical exam is different. So all the things that you guys learned, that's totally not normal. That's already there. You know what you're looking for, you know what you're examining, but the approach will be a little bit of different. Okay, let me do this physical exam and then you guys will understand how we should do that. Okay. All right, so let's start. So in here, first patient's father name is David, the son name is John. Okay, this is very important to address the patient's name by their name. You cannot just say any other name. So always try to write down the names in your paper. You will be allowed to have a paper and pen in front. So write down the patient's name because it's really help and you have to address with their name. So say, hi, John, or not John, David. So hi, David. This is Arshan, one of the doctor here. I got to know from the notes that your child, John, is having this rash. I'm really sorry to hear about that. Please don't worry. Now that you are here, I'll try my best to find out the cause of the rash. John will be fine. Now, to do that, I need to do a head-to-toe physical examination looking for any possible reason of this rash. That will involve me having a look at him, or that will involve me to examine him head to toe, including his hands, forearm, face, including the ear, nose, and throat, his chest, tummy, and the lower legs. During the examination, I will be as gentle as possible. But if you still feel that this is not appropriate or your child is feeling uncomfortable, please stop me at any time. Is that all right with you if we proceed, David? Yes, doctor, that's fine. Now, David, for the purpose of the exam, I need a full exposure of John. So I need all the clothes to be out, but he can put his shorts on. Is that okay? Yes, doctor. All right, David, now I'm going to start my physical exam. I will tell you the steps that involves with the physical exam, and during my conversation with you, I will talk with my examiner time to time. Please excuse me for any medical jargon that I speak. So I will start with just looking at John. So dear examiner, I'm looking for any obvious sign of distress, irritability, or any sign of drowsiness. David, I'm looking at his vitals. So examiner, I'm looking for blood pressure, pulse rate, respiratory rate, temperature, and oxygen saturation first, just to make sure John is stable. Now, David, I'm going to start looking at his rash first, but would you please tell me where is the rash and how does it look like? So it will just give you an idea that how does it look like? Like, is it a maculopapular rash or is it a purpuric rash? So you'll just get an idea. Now, if you don't want to ask this, that's totally fine. They're not going to fail you for that. Most of the time, they will give you this information in the stem. Okay. All right. So David, I'm going to look into the rash first. So first, by looking, dear examiner, on inspection, I'm looking for the site of the rash, distribution of the rash, and extent of the rash. Looking for the morphology and texture. So I'm looking for, is it a maculopapular rash, vesicular, or a purpuric rash? I'm looking for any obvious discharge, any scratch marks, or any scales. On palpation, I'm looking for any change of temperature, any tenderness, is it palpable or not, and is it blanchable or not? So what I'm doing, I'm just saying to David that I'm looking into the rash or I'm examining the rash. And then all the things I'm just telling to my examiner. So this is exactly what you can do in this sort of task. Okay. So David, I'm starting to look at his hand first. So dear examiner, I'm looking for leukonychia, koilonychia, clubbing, palmar erythema, or any pallor. Starting at the forearm, examiner, I'm looking for any bleeding spots, bruising, petechiae, purpura, scratch marks, or any injection marks. Now, David, I'll move upward to the elbow. Dear examiner, I'm looking for any epitrochlear lymph node enlargement. Then, David, I'm going to examine John's face. I will look into his eye, ear, nose, and mouth for any possible reasons of the rash. Is that okay? Yes, doctor. Dear examiner, on examining the eye, I'm looking for any pallor icterus, any conjunctival hemorrhage or injection. Also, with the consent of the father, I will use the fundoscopy to look into the retina for any possible retinal hemorrhage. I'm looking into the ear for any bleeding and discharge. And also, again, with the consent of the parents, I would like to use the otoscopy to look into the ear for any bleeding that I cannot see in the naked eye. I'm looking into the nose for any epistaxis. In the mouth, I'm looking for gum bleeding, hypertrophy, any tonsillar enlargement, exudates, pharyngeal erythema, palatal petechiae, glossitis cheilosis, strawberry tongue, and any dry cracked lips. I'll discuss everything to you guys. I'm just showing you how you should do. David, now that we have finished with the face exam, I'll move downwards. I'm checking into the neck and axilla. Dear examiner, I'm looking for any cervical or axillary lymphadenopathy. Then I move to the chest, David. In the chest, I will then I will move into the chest, David. Dear examiner, I'm checking for any sternal tenderness. After looking into the chest, David, I'm looking into the tummy of John. So dear examiner, on inspection, is there any scratch mark, any bruise, any visible vein or mass? On palpation, is there any organomegaly or any tenderness? And on auscultation, is the bowel sound audible? With the Now you would say, David, I need your consent to look into John's back passes for any possible bleeding from there. And also I will look into any lymph node enlargement in his groin area. Is that all right with you? Yes, doctor. So dear examiner, I will look for any parectal bleeding and inguinal lymphadenopathy. I'll look into the leg now. So dear examiner, I'm looking for any sign of bruising, purpura, petechiae, scratch mark, or any popliteal lymphadenopathy. And lastly, David, I will finish with doing a musculoskeletal system exam, which means I'm looking into the joints mainly. Examiner, I'm looking for any swelling, any tenderness in the joints. I will finish my exam looking for any office test available, including the urine dipstick. So that's how you finish this case. Okay, that's your physical exam. Now you see, it should not, if you know what you're looking for, it should not take even more than 5 minutes, max 6 minutes. Okay, if you are just stuttering, then it will take highest 6 minutes. Then you have time to say this diagnosis with reasons. In here, because it's most likely looking like it's a EVV rash or antibiotic induced EVV rash. So you'll say in here, David, with the history of sore throat and starting the antibiotic, John started to have this rash, and also looking into his body from head to toe during the physical exam, I'm suspecting most likely the sore throat your child had was due to a condition called Epstein-Barr virus infection, or we call it infectious mononucleosis. It is caused by a virus which usually spreads through infected person's saliva, like kissing, sharing drinks and food, using the same cups, eating utensils, like using the same utensils or toothbrushes, or sometimes even with direct contact. In 5% cases, it can itself cause a non-itchy rash, but in 95% cases, patient with infectious mononucleosis, if they are given penicillin, they sometimes present with a generalized itchy red rash all over the body, which exactly I am thinking your child is having. It could be due to other causes as well, like it could be, then you can say all this differential, it could be viral, any other viral rash, could be allergic rash, any drug-induced rash apart from amoxicillin. It could be sometimes any cancer of the body like leukemia, lymphoma, but please don't get stressed. I haven't found anything goes with this. Could be ITP or immune thrombocytopenic purpura, but the characteristic of the rash doesn't go with it. Could be Hennescheren purpura, again, characteristic of the rash and also the examination findings doesn't go with that. Okay, so this is how you will give your differential diagnosis. Now, it can seem to you that we don't know any finding, how we are ruling out differentials. So most of the time, they are not bothered with that because they know that they haven't given you enough information to give this differential diagnosis. So in case you just tell the differentials, that's also fine. At least just talk about this differential. Why I started with viral, allergic, and drug rash in here, because most likely this would be a blanchable rash. Okay, sometimes during the exam, you can find a non-blanchable rash. then your differential diagnosis would be any of these four. Okay, ITP, HSP, meningococcemia, and leukemia. These four usually gives you a non-blanchable rash. Others are all blanchable. Blanchable rash are not very serious, but if it comes as a non-blanchable, it's always we look for the serious things like meningococcemia, leukemia. These are serious. Okay. So depending on your finding, or at least your understanding, give your differential in that order. Okay. It's like, yes, it's like a running commentary to the examiner. That's right. Okay. And yes, like Dr. Kuki, I like during my talking, I was actually explaining many things. So I can take a little bit of more time. That's fine. Don't bother with that. And also, I was a little slow. In your exam, you have to be a little bit more fast. Okay. So try to do it with your time. When you're just telling about examination findings, it should not take more than 5 or 6 minutes. Okay. It's not very hard. So do you guys understand how to do that? Does that help? Now, David will not answer, Dr. Hafsa. David, that means the role player will not answer any specific finding. But obviously, David knows where exactly is the rash and how the rash looks like. Now, many times they might not even instructed to do so. Then if you ask, they will not answer your questions. But if they know, they will answer. Okay, so you can just ask the site of the rash, that's fine. Even if you don't ask, that's totally fine. Yes, yes, Dr. Onur, that's very, this way, you can finish in a very nice and fast way. This is a very good way. Now, you have to always say, look, that how the task comes. If your task is that you just need to talk the step of examination, a step involves only what you are looking for. Okay, a step doesn't involve that you are looking for colonychia, leukonychia, lymph node. If you do that, the role player will ask you a lot of questions. What is lymph node? What is pallor? What is colonychia? What is leukonychia? You will not be able to finish the exam. Okay, if you need to explain each and every medical jargon, you are not going to finish the exam. That's impossible. So this way is good. So is it necessary to talk in between to father? What if we finish first task with father, then we totally talk with father? Now, I don't think, Dr. Taiba, I don't think it will be appropriate, because what will happen exactly how Dr. Najia did, if you do that way, like first you say all the things to the father, then you come to the examiner, again repeat the same thing to the examiner, it will not look nice. Now you can do that. It's not like there is no hard and fast rule. If you do that, do it properly. If you just want to say the step, like I'm going to look into this, then you want to just talk with the examiner, that's okay. But in my experience, involving the patient or role player is must. You have to always involve your role player. So the way what I did, I involved my patient. Throughout my conversation with the examiner, I tried to involve my patient, and that's very good. Okay, always try to involve your patient. Now, I'm going to talk about how to do with the medical student. Don't bother. So let me explain the questions, how to show or tell here about washing my hands. So you don't need to say. In here, you can just say, Dr. Farhana, very good point. So when you say, I needed total exposure of John can only have his shorts on. So during this time, I will just wash my hands and come back to you. So you just say that you're going to wash your hands. I think I missed that part. So yes, that's a good point. So you just say that you want to wash your hand and then you come back. Very good, Dr. Farhana. Medical student comes next. Yes, Dr. Lulu, examiner will not give you any finding. Yes, Dr. Gina, you can add that. If you think that this is a anaphylactic reaction, you can add swollen tongue. You can ask about wheezing, cyanosis. That's fine. Because why I haven't kept it, because this question is not full. In the full question, they will give you the timing of the rash. Most of the time, EVB induced rash, like antibiotic causing the rash in EVB patient, that comes usually after like 5 to 7 days. So it cannot be anaphylactic shock if it comes after 5 to 7 days. So that's why I haven't kept it. But if it comes immediately after the antibiotic, then obviously keep it. What do you mean by explain to examiner, Dr. Hafsa? What is your question? Yes, Dr. Hafsa, that means you explaining your, like whatever you are doing, you are telling it to the examiner. That is your second task. Tell what finding you are looking for. See that if they're asking this finding, they would also say it here. That's why they said step and they said finding in the second task. That's why you don't need to do it like twice. Now that's a good one, Dr. Nadia. So you can always tell that. If you heard how when I did, I also tried to like justify why I am looking for these findings. Now try not to do it for everything because it will not sound good. Sometimes like when you are saying about external tenderness, you can say that you're looking for any bony tenderness for leukemia. Okay, so justification is always good. That shows that you know what you are looking for and why you are looking for. Add it like in between your examination, add this justification whenever you feel comfortable. Like yes, in epitrochlear lymph node, you can always talk about lymphoma. In cervical inguinal lymph node, you can always talk about lymphoma. And that's very good. They're not going to give you, Dr. Najia, that they're not going to give you that ask finding or tell your finding to the father, because that time it becomes really irrelevant because you need to talk about everything in a non-medical jargon. And unfortunately, if it comes, then you have to explain everything in a non-medical jargon. That means what is lymph node, what is koilonaikia, leukonaikia, you have to do it all. That's why I don't think that they will give these sort of things. How do we assess hemodynamic stability before doing PE? Very good question, Dr. Joy. You are not going to get any findings. Most of the time, they will give you the vitals stable or maybe the vitals in the stem. If it is not given, then you just say that you are going to check the vitals. In that way, you just covered that. You may not be able to find the findings, but you can cover it. As you can see, I told also that I'm going to look into the vitals. Okay. Now, that part, they can give you picture of rash, they cannot. I haven't seen they have given so far, but they can give you. So all medical jargon to examiner, no medical jargon to the patient. That's right. Yes. So that's the thing. Like recently, not recently, there was previously that sometimes you need to explain newborn examination to the mother. That's also with a non-medical way, you have to do that. Now, yes, they can give you also that if they want us to explain these physical exam findings to the mother or to the parents or to the role player, then in that case, we have to just use all the non-medical jargons. Like in this case, you have to say in this way, John, David, I'm looking into the rash for this, for how it looks like. Is there looking for any discharge? Is there any scales coming out of it? Any change of temperature? I'm looking for, does it hurt when I press? Does it blanch when I press? I look for that if I can feel the lump, feel the rash. So I'm looking for palpability. So you have to explain everything in non-medical jargon. So then, and in the hand, you have to say that in the hand, I'm looking for any whitish color, discoloration of the nail, which I call leukonychia. I'm looking for any spooning of the nail, which is koilonychia. I'm looking for any loss of angle between nail and nail bed, that is clubbing. Now, that's really hard, but you have to explain in that way. Okay, in that case, you have to cut short your examination. That means you don't need to say everything at that time. Just say the findings in a like whatever you are comfortable. Like if you are not comfortable about explaining koilonychia, forget about it. Don't say that. No. So that's a very good question. How to differentiate between the primary rash of EVV and the antibiotic induced rash? Now, Epstein-Barr virus primarily can cause a rash, and that rash is non-itchy. Okay, non-itchy rash. But the rash that comes after antibiotic, let's say itchy rash, which is maculopapular or sometimes morbilliform rash, and both of these rash will be blanchable. Okay, so with blanchability, you cannot differentiate. You can only differentiate by the look of it, like is it itchy or non-itchy. Yes, antibiotic-induced rash is also blanchable. That's right. Only non-blanchable rash are those four: ITP, HHP, leukemia, meningococcemia. Okay. All right. Good. Let's move on. We'll go through all of these things. Now, they can mention, they cannot, doctor. Most of the time, they are not mentioning that is it itchy or blanchable, but you always talk about the common findings. Common is 95%. Common is antibiotic causing the rash in a EVV patient. That's common, so give your diagnosis as a common one. I know this is hard, but again, we don't have anything to do. They're not giving us enough findings. Now, these are other hematological findings, hematological cases. As you can see, one of the case is pre-operative assessment of a patient, which showing low platelet. So anything related to rash or low platelet, anemia, all comes under the hematological physical examination. Okay, so preoperative assessment of a patient having low platelet, that's hematological. Sometimes what we exactly did today, that can also come with rash at the lower limb, and you will find a non-blanchable rash, that's ITP rash. Sometimes also comes mentally retarded patient having a rash in the leg, maybe it could be a HSP rash. Sometimes comes with a unilateral inguinal lymph node enlargement that you are mainly ruling out lymphoma. That's also hematological PE. Sometimes comes as a pregnant woman, you find out the hemoglobin is low. That's also hematological PE. So hematological physical examination is a very, very important physical exam, and there is a lot of case falls under one particular cluster. Okay, so this is how the cases can come. I will discuss the hematological PE, but I want any of you to come up to do it on a medical student. Now, mentally retarded patient, there will be another guardian with the patient. So you don't need to talk with the mentally retarded patient. Probably there will be another person. The role player will not be mentally retarded. So who want to do the role play on the medical student on this particular case? All right, Dr. Honor, I will unmute you.
Hello, can you hear me?
Yes, I can hear you.
Hello,
Hi, doctor.
doctor.
How are you?
I'm good, very well. How are you?
Yeah, fine, thanks.
Thank you.
So now we are going to do the same physical exam, but you need to explain it to a medical student. So your task is same.
No problem.
So this is exactly the case, but the task is a little different. That means in here, you don't need to talk with the father. You in here, like there is a medical student with you. You need to explain to the medical student that what examination you are going to do, and then tell him the diagnosis with reasons.
No problem. What is the name of my medical student?
Your medical student name is George.
George, okay.
I'll give you 1 minute time just to think that what you're going to do. Okay?
No problem.
Okay, so you will get 7 minute time to do that. Okay, because your task is 2 tasks. Now, let's start.
Okay.
So, hi doctor, can I check your ID, please?
Here's my ID.
Okay, so doctor, this is the medical student with you. You can talk with the medical student. His name is George. Please proceed.
Okay, thank you very much. Hello, George. My name is Onur. I'm one of the doctors here, and I will be taking care of our patient, John, and I will be explaining you to the examination steps and what examination we need to do with our patient and how are we going to do that. During the examination, please just do not hesitate to stop me if you don't understand any technique or if you have any connection right at the moment, all right? And
Yes.
George, I will be starting with actually the explanation of this examination to the father. This is very important. We need to explain all the steps and what are we going to do and what do we need to do with our patient, especially the exposure of our patient will be needed. And because of that, we need the consent of father. And for that reason, we are going to talk with the father. Then we will be starting with washing our hands. This is very important step. We don't need to, we shouldn't just forget this step. And then proper exposure and also the just the position of the patient will be important as well. As we know from the information, from just the patient's information, our patients have had a sore throat. And after that, he had some antibiotic, and then he started having this rash. For that reason, we need to do we need to do a full head-to-toe examination to John, and for that reason, we are going to be starting with the general appearance of our patient first. And on general appearance, we are looking for, George, any obvious actually sign of just a distressing of the patient, any lethargia of our patient, or any drowsiness. And also we are looking for any dehydration signs, and also if our patient just has maybe just what else actually yeah, that is actually the main thing we are looking for. Do you like me to explain to you how do we check the dehydration signs, and or how do we check just the general appearance, that sort of thing?
That's fine. Yeah.
That's fine. Okay, you just as I said that before, just please do not hesitate to ask me that. So then we are going forward to the checking the vital signs of our patient. This is very important as well. We need to check especially the blood pressure and the pulse rate and the oxygen saturation, respiratory rate, and the temperature of our patient. Because as we are suspicious about the differential diagnosis, as just with both blanchable and non-blanchable causes of the rash, we need to evaluate these vital signs are very crucial. And then we are going on the rash examination. On rash examination, there are some important steps we need to be just evaluating, and we need to be just checking. So what is this? We need to check what is the we need to have a look actually at the rash. If we see what is the distribution of this rash, and what is where is this what is the side of this rash, and if it is going anywhere else as well, and the morphology of this rash is very important. If anything is oozing from this rash, and if there is any scratch marks around that, if it is scaling or not, very important. And after that, we will be going on the palpation, the feeling part of this examination, and we'll be checking this rash if it is hot to touch, or if it is tender, if it is painful to touch. So for that reason, after that, what is the most important step of this rash examination is that if it is blanchable or not blanchable. And there is a particular way to check it. We are going to press with just a glass, with a transparent glass, and we will be checking if it is blanchable or not blanchable. So in that case, if it is blanchable, there are some reasons. Some viral infections could be, and other just antibiotic related, just a medication related, or it could, if it is non-blanchable, it could be some serious conditions such as the meningitis or HSP or ITP, or just some also the ITP, and that sort of actually the things it can be happening. And the leukemia, I'm sorry, the malignancy is the leukemia. Then we are going to move on the hand examination. Hand examination include having a look at, again, inspection of the hand. We are looking for any colonesia, if there is any splinter hemorrhagia, if there is any just pulmonary erythema. And while we are looking at the hand, we are checking the capillary refill time as well. We need to check it. And then we are going to the elbow examination above. And the elbow examination, including the epithelial lymph node, is very crucial to check and hit, especially we are suspicious about it if there is any malignancies. And the epithelial node examination with the palpation especially very crucial. Then we'll be going up the face. On the face, we are looking for any jaundice, and also if there is any paleness, checking the sclera for the jaundice and the conjunctiva for the pallor. And then we need to do a full ENT examination, which involves us just having a look just the ears, and we using this otoscope, and also we need to use this fundoscope to have a look at the back of the eyes, retina as well. And we need to check nose if there is any septal deviation, if there is any hematoma, if there is any bleeding from nose, and mouth as well. We need to have a look at if there is any gum bleeding, gum hypertrophia, glossitis, and if there is an enlarged tonsils, if any exodus, and other things. And also we need to do full lymph node examination on the neck, so supraclavicular, infraclavicular, and also the all cervical lymph nodes, periauricular, postauricular, and also the other groups as well, axillar and inguinal lymph nodes as well. If it is possible, abdominal inguinal node, we need to check it as well. Then we are moving to the chest quickly. We are checking if there is any bony tenderness on the chest, any on the ribs or sternum. Then we'll be looking on the abdominal examination very closely. On inspection, having a look at if there is any distension, if there is any visible bowel movements we are seeing, any scratch marks, any jaundice, and then we will be doing the auscultation if the bowel sounds are present, if they are hyperactive or normal active or hypoactive. Then we are going to the palpation, superficial and deep palpation. Especially superficial palpation, we are looking for any mass. Okay, I couldn't finish it.
That's all right, doctor. So you
All
did
right.
good, doctor.
Thank you.
Yeah, it was really good.
Thank you very
And
much.
Dr. Onur, right?
Yes, the honor.
Okay. All right. So it was good.
Mhm.
But what we can do, like, I think like the way you explained, that's totally fine. But try to be like, try to involve the medical student a little bit more. Like,
More, yeah.
don't ask them that, do you understand it, or do I need you to show how to check dehydration? Don't ask them, because they will say yes, it's fine.
Okay.
But the task in here will be like that, like you have to explain what you are examining in this patient with anatomical landmarks. Sometimes they add that also. So if that is a part, like anatomical landmark, you have to explain each and everything, that how you are going to examine a particular physical examination. Like you have to explain how to do clubbing, how to do checking the lymph node. Just now, it's not possible to say each and everything because we are looking for a lot in hematology. But you try to just cover that part of anatomical landmark so that they can mark you. So if you just explain a couple of it, like you know how to explain clubbing, so explain that. How to do a neck lymph node, just explain a little bit of it so that they can give you the mark in that particular task. Okay, and they cannot fail you if you just touch it. So in exam, it's really important to touch each and every point they are actually giving you marks. Otherwise, what will they do? Like you may get 4 4 4, but in one task 0. So globally it can come as a fail. So that's really important. Like you try to touch everything that's in your task.
All right.
Okay, at
that is
least
very
once or twice. Yeah. So let me explain that how we can improve what you did. But you did good.
Thank you very much. Appreciate it. Thank you.
No worries at all. Thanks. I'll just mute you. Okay. Guys, so as you can see that Dr. Honori has done good, but still we can improve a little bit more just to make sure that the examiner cannot fail us, right? We don't want to be failed. So the same thing, same approach is there. That means all the things that we're doing, that will be exactly same. But when you are teaching a medical student, think that you are the teacher, okay? Think you that you are teaching a medical student, how you are going to teach. Like I know that many of you worked in hospital and you have done this teaching to the medical student. Just think you in that place, in that position, and then you will understand that how you should do that. When you teach someone, you have to teach in a way that they understand. Maybe they are medical student, but what if this is a first year medical student? Have you asked it? Right? You have to ask it that what is the level of understanding for this particular medical student? A fifth year or fourth year medical student knows a lot of things, knows how to check clubbing, but a first year medical student may not be able to know that. So when you initially introduce yourself, try to find that out. Okay, that make a rapport with that medical student because he's going to pass you. Unfortunately, he will have point to pass you because examiner will ask the medical student, how do you feel about this examining? Okay, so that's important. So you have to make sure that you have that capability to teach a medical student. Now, If the same case, that means if we need to teach a medical student or we need to explain physical examination to a medical student, how we are going to do that? So let's start the initial thing. So when you introduce yourself, so you say that you know the name, so it's George, right? So you say, hi, George, this is Dr. Arshan. It's very nice to meet you, George. So can I please know that what year you are in at the moment? I'm really sorry to ask, but I would really like to know that. So can you tell me about it? Or you can start in that way. Don't bother too much asking. Say in that way. Hi, George. This is Dr. Arshan, one of the doctor here. It's very nice to meet you. Can I please know that what year you are in at the moment? Doctor, I'm fourth year medical student. Oh, that's great. How you are enjoying your medical life, George? It must be really exciting for you. So what you are doing, you are showing to the examiner that you don't care too much just for passing this exam. You care much about making a rapport with this medical student. And that is really important. If you show someone that, yes, I'm desperately want to just pass this exam, I don't care about my patient, I don't care about anything, that's not going to help. You have to act just just like how you would do if this was a real situation, right? In real situation, obviously you would ask this medical student, like, what year you are in, how you are enjoying this, are you having any trouble? So please let me know if you're feeling anything, any difficulty. So this is how you make a rapport with a person, right? And you have to show it in the exam also. Do that, and then you say, George, today we have got a patient that I want to discuss with you. The patient is a 5 years old child. His father is here. He's very worried because he has a sore throat initially, and he was given antibiotic penicillin. And the child started to have the rash 5 to 7 days later on. Now we are going to do a physical examination to find out the cause of this rash. And I'm going to show you how to do that. During my conversation, if you don't understand anything, please let me know. So first of all, before doing any physical examination, you have to understand that we need to follow a particular approach. First thing is wash your hands, and then we have to introduce ourselves with the patient that this is us and we are the doctor here, want to do this examination. You need to take permission about whatever examination you are going to do. Like in this case, you need to ask permission from the father that you are going to do a head-to-toe examination, including the hand, face, ear, nose, throat, chest, tummy, and also the lower leg. And most importantly, also you need to have a proper exposure of this patient. And always try to say it to the parents whenever you are going to do that. Once you have done with this initial approach, then you will start your physical examination. So in this part, we will first start with general appearance. In the general appearance, mainly you will look for any obvious sign of any distress, any irritability, any sign of drowsiness, anything you can see obviously that you look into general appearance. Then you look into the vitals of this patient to make sure that he is stable. So you look for blood pressure, pulse, respiratory rate, temperature, and saturation. Most of the time, you will be able to get it in the patient's vital chart. Then, because this patient is having a rash, start with examining the rash first. So what we are going to do, we will do an inspection and palpation. On inspection, we should look into the site where exactly is the rash, distribution of the rash, like is it in the whole body or any specific part of the body. Now, when you are doing that, guys, try to show try to move your hand, always, because you cannot show it on a patient, you are just explaining, always try to move your hand, show it with your gesture, show it with your hand that what you are doing. Okay, I can't show it to you, unfortunately, but try to show it, okay, in the exam, because your video will be on at that time. Then we are looking for the morphology of this rash, like is it a vesicular, maculopapular, or it's a kind of like a purpuric rash. We'll look for any obvious discharge, any scratch mark, or any scales. After that, we will do a palpation. First of all, you check the temperature. When you check temperature, try to do it with the dorsum of your hand, and first start checking the temperature with the normal part first, and then check the abnormal one. Show it with your hand. Then you just palpate the rash area, checking for any tenderness. Palpate to see if you can palpate the rash. Many of the rash can be palpable. And the most importantly, we have to find out if it's blanchable or not. For that, just press on the rash with a glass and see if it blanch or not. Is that all right with you so far, George? Yes. Once you have done with the rash, then start with the hand and then move upwards. On the hand, you look for leukonychia, which is whitening of the nail. You look for koilonychia, which is a spoon-shaped nail. You look for clubbing. So in clubbing, what you need to do, you ask the patient to put their index finger together, and you look in the middle for a diamond-shaped gap. Normal patient should have that gap, but in person with clubbing, that diamond-shaped gap will be disappeared, and then we know this is clubbing. You also look for any erythema in the palm, which we call palmar erythema, and look for any generalized pallor in the hand for any anemia. Go into the forearm for any bleeding spot, bruises, petechia, and purpura. These petechia and purpura are kind of bleeding spots. So the petechia, small minute spot, which is less than 2 millimeter. When it's more than 2 millimeter, that's purpura. You look for any scratch marks and any injection marks as well. Once you are done with that, move into the elbow for a very important examination, which is epitrochleal lymph node. In epitrochleal lymph node exam, what you need to do, you need to hold the patient's hand with one of your hand, or you can say that if you are examining the patient's left hand, hold the left hand with your left hand, and then palpate the epitrochleal lymph node with your right hand. Make sure that you put your thumb on the medial aspect of the elbow and the other 4 fingers on the lateral aspect of the elbow. You can always show it to the medical student. That will be easy and fast. What I am doing, the important landmark I am touching. Epitrochleal lymph node is an important landmark. If anatomical landmark is a task, you have to explain a couple of landmarks. Okay. Then you move to the face. In the face, you start with the eye, looking for any pallor, icterus, any conjunctival hemorrhage or injection. Also, we will do a fundoscopy to look into the eye for any retinal hemorrhage. Then you look into the ear for any obvious bleeding or discharge. And also with the otoscope, you look into the ear for any damage to the tympanic membrane or any bleeding that you cannot see by naked eye. With the nasal speculum, look into the nose for any epistaxis. Then look into the mouth. Ask the patient to open the mouth and then use a tongue depressor to look into the mouth. Also try to use a light source so that you can look better. So you look for any gum bleeding, any hypertrophy of the gum. This mainly helps us to look for any leukemic findings. Look into the tonsil for any enlargement, any exudates, any pharyngeal erythema, or palatal petechiae. These are mainly related to Epstein-Barr virus infections, where you can get tonsillar enlargement, exudates, or palatal petechiae. Look into any strawberry tongue. Sometimes children can have a rash related to scarlet fever, so that's why we are looking for it. You can look into glossitis chiliosis, which most likely related to iron deficiency anemia. So now I am also trying to tell the medical student why I am looking at. Now, remember, it can take a lot of time. It always depends that how you are moving. If you see that you are moving out of time or you are explaining it too much, then you stop there. You just move on, just touching the point. But at least discuss a little bit, like epitrochleal lymph node, discuss it. Then move into the neck and axilla for checking the cervical lymph node and axillary lymph node. George, I will show you how to specifically palpate the lymph node later on. Now, that's for if you are running out of time. If you are not running out of time, you can at least say that what are the lymph node you are looking for. Then you move into the chest. You press with the thumb into the sternum of the patient, checking for any bony tenderness. That's mainly we are looking for leukemic findings. After that, we move into the abdomen. Abdomen, you can do it on inspection, palpation, and auscultation. On inspection, we are looking for any scratch mark, visible veins, visible mass, or any distension, or any sign of rash or bruising or bleeding. On palpation, you do superficial and deep palpation, checking for any tenderness or any palpable mass. And then also, very importantly, we need to check the liver and spleen for any enlargement. I will show you how to do that later on. And then with the consent of the parent, you should always look for any parietal bleeding and any inguinal lymphadenopathy. Lastly, you look into the leg for any sign of bruising, purpura, petechiae, scratch mark, or any popliteal lymph node. You can also do a musculoskeletal system exam, mainly just look into the joint for any swelling and tenderness. That will help you to rule out any Henoch-Schönlein purpura induced symptoms. So that exactly is how we are going to do a physical examination for this particular patient. George, I understand that this is a lot to take in at this time, and I have a lot to discuss with you about most of the other findings. So I will try my best to take another time with you to show you how to palpate lymph node, how to do this abdominal examination. All right. Now, what I have done, I expressed my trouble with the medical student that I don't have enough time to show everything, but I will do that with you. Okay, so you are just saying that at least. So whenever you are running out of time, you just tell that you are going to do that. At least you are like telling the student that yes, this is hard to get in one time. Obviously, like a hematological examination includes the whole body, right? It's very hard to finish, and showing everything is not possible. Examiner also know that. If you just touch a little bit, like when I did the epitrochlear lymph node, I passed the anatomical landmark. Okay. Sometimes if you can just touch how to do the cervical lymph node exam, you pass that anatomical landmark. So that's how you do that. And you also explain a lot, right? Why you are doing that, how you are doing that. So you justified everything. And that's how you should do that. Clear, guys? I know that there is a lot of things in here, but in here, your task is only to explain the physical examination to the medical student. You are showing to the medical student how you are doing it, and also with anatomical landmarks. So these are the things that I have written for you. So for colonychia, use the term spoon-shaped nails. For leuonychia, whitening of the nail bed. For palmar erythema, redness of the palmar aspect of the hand. Clubbing, you can say that when there is a loss of angle between the nail and nail bed. Cyanosis, bluish discoloration of the nail. So these are the findings. This is how you stop with the medical student. Forearm. In the forearm, if you want to explain petechiae and purpura, just say that they are a small pinpoint spot. Smaller one, less than 2 millimeter is petechiae, more than 2 millimeter is purpura. Epitrochlear lymph node, you can say the lymph node that lies medial to the elbow. And then you can explain how you are going to check that. Face pallor icterus, if you have time, you can also say that how you are going to check pallor and icterus. In pallor, you ask the patient to pull down the lower eyelid and you look for conjunctival pallor. In icterus, you lift up the upper eyelid and look for any yellowish discoloration of upper sclera. So that is how you check anemia and jaundice. You can also explain to the medical student if you have enough time. Lymph node. Now, cervical lymph node, axillary lymph node, these are very important part of physical exam. And if anatomical landmark is your task, sometimes you may need to address that. So it's a good idea to know how to tell that you are going to check cervical lymph node in a medical student. Okay. Am I discussing a lot, guys? Are you guys with me? Very, very good, Dr. Shova. Yes, that would be a really good thing to do. Like in the introduction, you can always, the problem in here that father will not be in, like with you. Only the medical student will be with you. What you can say to the medical student that you introduce yourself with the medical student, and before you start physical exam, you can say, George, before we start examining you, examining the patient, we need to take permission from the father that I need to share all this information with you. And if the father is happy, then we will proceed. You can talk about it. That's fine. But normally you are talking about permission also. It should cover in that way. But if you do that, I think that's also a very good idea. Dr. Shova, you can always do that. Good. All right. So now I'm just showing you how to tell cervical lymph node examination to the medical student. If you look at here, this is exactly what you're looking for. In cervical lymph node, you look into the submental lymph node in here under the chin. Then you move upwards. In here, you look into the submandibular lymph nodes. You move upward around here. That's your pre-auricular lymph node. That's your post-auricular lymph node. Sometimes in here, at the angle of the mandible, you can also find a jugulodigastric lymph node. That's for mainly tonsils enlargement. Then you move into the along the sternocleidomastoid muscle. Anterior to that muscle, you have anterior cervical lymph node. Posterior to that muscle, you have posterior cervical lymph node. And lastly, also you check for, before that you check for occipital protuberance for occipital lymph node. And lastly, you go for supraclavicular lymph nodes. So these are the lymph nodes in the cervical area that you look for: submental, submandibular, jugulodigastric, preauricular, postauricular, anterior cervical, posterior cervical, occipital, and supraclavicular. Now, problem is previously you don't need to even know about these things because you would just examine that. Now the problem is you have to know everything, and that's bothers also, right? Because now you need to go into detail about all this lymph node, where it is, from where it supplies. So it's a pain in the ass, but we have to do it. Okay. Now, when we examine cervical lymph node in a patient and we are explaining it to a medical student, just try to be very simple and shortcut. So say that, George, when we are examining cervical lymph node in a patient, we ask the patient to sit upright and try to examine the patient from behind. You can also examine from front if it's not possible to examine from behind. Ask the patient to tilt their chin slightly downwards to relax their muscle of the neck. And then with your second, third, and fourth finger, you start feeling under the chin, which is the submental lymph node. You can always show it with your hand. Then move posteriorly under the mandible for submandibular. Turn upwards at the angle of the mandible for jugulodigastric. Feel the front of the ear for preauricular, back of the ear for postauricular lymph node. Then you follow the anterior border of the sternocleidomastoid muscle down to the clavicle, that's for anterior cervical, and then palpate behind this muscle for posterior cervical. Once you have done that, palpate over the occipital protuberance for occipital lymph node, and then ask the patient to shrug the shoulder, palpate behind the clavicular border for in the supraclavicular fossa for supraclavicular lymph nodes. So that's how you explain how to check cervical lymph node to a medical student. If you're running out of time, you can just say, George, when you check cervical lymph node, you are with the finger of your second, third, and fourth finger, you're looking into you should palpate the lymph node under the chin, which is submental, go upward for submandibular, jugulodigastric, anterior preauricular, postauricular, anterior cervical, posterior cervical, occipital, and supraclavicular. When you do that, you are just showing it with your hand and you are showing it on your face. Okay, so that's how you do it first. If you have time, then you explain. Always make sure you know how to do both way, because in exam, you will not know how the time can go. Which slide, Dr. Gina? This one? All right, so let's finish our hematological examination. Do you guys have any question on hematological P? First of all, this is how you are going to do the physical exam. I haven't actually explained to you, but I think already you should know that we did it 2 times. So these are the things that you look for. So I'm not going into discussing it again. I have kept another case today. Any of you wants to do a role play? We'll just be very short and we'll just show you how to do that. But I'm suspicious that that case is more difficult than this case. I kept the slides for axillary lymph node. I'll not explain it now. Yes, Dr. Nipi, you will get this video in your software. All the course students will get the video. That's fine. Don't worry on that. All right, Dr. Mukta, very good. I was hoping that you were going to come. Your exam is near, Dr. Mukta. Oh, I haven't unmuted you. Let me unmute you.
Hello.
Hi, doctor. How are you?
Yeah, good. How are you, doctor?
Yes, I'm fine. Thanks. Okay, so let's start. You've got a very tough physical exam, but I guess you should be able to do that.
I'm not sure.
Okay, so that's your case. And your
Okay.
2-minute time start. Okay.
Mm.
Hi, doctor. Can I check your ID, please?
Yes.
So this is the medical student with you today. His name is John. You can start. And also the patient name is David.
Okay. Hello, John. I'm Dr. Mukta, one of the doctor here. So, John, nice to meet you. May I know which year you are studying?
I'm 5th year, doctor.
Okay. So, John, how is your study going on? Are you enjoying your studies?
Yes, doctor. I'm enjoying my studies.
Okay. So, John, how is your study going on? Are you enjoying your studies?
Yes, doctor. I'm enjoying my studies. Oh, it's tough, but yes, I'm enjoying.
Okay. So John, today I will discuss with you about one of my about the examination of one of my patient uh, who is 30 years old male, came with knife injury at the flexor aspect of the left wrist. So in this case, as because my patient come with knife injury, first of all, we need to make sure that whether my patient is vitally stable or not. Okay. So for that, we will
Okay.
proceed with the DRS ABC protocol, and then we'll start the examination. Okay. So,
Okay.
John, now before starting the examination, we need to take consent from the patient, and also we need to wash our hands. Okay. And today our examination will involve look the hand, also the cut area, feel, and also we need to check the sensation of different parts of the hand, as well as we need to check the movement of the hand. Okay. And
Yeah.
also we need to do some spatial tests. So John, are you with me so far?
Yes, doctor.
If you can't understand anything, whatever I explained to you, just let me know. I'll again explain. Okay.
Okay.
So John, at the beginning, we'll start with the general appearance of the patient. Okay. First, we need to check whether patient is any distress or patient is in any pain. If patient is any pain, first we need to make sure patient is comfortable. So for that, we need to arrange painkiller for our patient. Okay.
Okay.
After that, we can start the examination. In the examination, first of all, in the knife cut, we need to check whether the details of the card, like it's a horizontal or vertical card, then there is any bleeding discharge come from the card, and whether any redness, swelling present, or any other bruise mark in the hand. Okay. As well as we need to check the position of the hand, because we always expect in this type of cut injury there might be some muscles, tendons, or some nerve or artery can be involved. So if there is any muscle involved, then the hand position can be changed. Okay. And also we
Okay.
need to check the color of the hand, whether any circulation compromised or not, to make sure that. John, are you with me so far?
Yes.
Okay. After that, we need to check the first of all temperature of the hand, whether any cold coming skin of the hand, and compare with the normal hand. And here, John, I want to mention before palpation, in the inspection, actually we need to check dorsum of the hand as well. There is any scar, any swelling, any muscle wasting, as well as any deformity there. Okay. After that, you in the palpation, we'll check the palpation with temperature. So we'll check with the dorsum of the hand and compare with the other hand as well. Okay. Whether
Okay.
there is any cold coming skin. So we'll then understand there might be some loss of peripheral circulation. Okay. Or we can, if there is any type of rise of temperature, though it's very less likely that we think about that, it might be there is some inflammation going on. After that, we need to check the capillary refill time. Again, we need to press the nail bed of the patient, is normally less than 2 seconds. So if it's more than 2 seconds, then also we think about there are some problem with the circulation. Then we need to check the tenderness. In this case, we need to be very gentle. We can check the below portion of the cut, and as well as the above portion. Okay. After that, we need to check now we can proceed with the pulse. In this case, in this hand, maybe if we won't get the radial pulse, we can go for the brachial pulse, as well as we can check radial pulse in the other hand. John, are you with me so far?
Yes.
Okay. So is that clear up till now?
Yes.
Okay. Now we need to check the sensation because I told you before here some nerve might be involved. So there chance of getting injured of the median nerve, ulnar nerve, as well as radial nerve. So for that, we need to check the sensation. For that, we can use the cotton wool. First, we need to touch the cotton wool in the chest of the patient. And then we need to tell the patient to close their eyes. Then we'll check the sensation of the affected hand as well as we will compare both. So for that, we will first check the index finger of the both hand, then thinner eminence of the both hand for the median nerve, and then little finger and hypothinner eminence we will compare with the both hand for the ulnar nerve. Then we will check in the anatomical snap box for the radial nerve. Okay, and also we can check with the pinprick also same sensation. John, is that clear to you?
Yes, doctor.
Now we'll check the movement. Okay, because I told you there in the flexor compartment there are three types of muscles like flexor carpi radialis on the radial side. In the middle there is palmaris longus, as well as there is in the ulnar side, I mean in the medial side of your hand, there is flexor carpi ulnaris. Okay, and also there are some deep flexor as well, like flexor digitorum profundus as well as superficialis. Okay, so in this case, first of all, you need to check movement. You need to we need to check the flexion of the wrist, extension of the wrist, radial deviation as well as ulnar deviation. Then we need to check the finger flexion. For that, we need to check the finger flexion, extension, abduction, and as well as adduction. Okay, time is up.
Okay, thank you, Dr. Mukta. So it was
Sorry.
good, but what I think that what happened with the time problem, this is new thing for you, right? So you're still trying to adapt with the full change in the physical examination, and that's normal. Don't worry on that. It will be fine. I know that it's gonna be fine. But the thing is like you have to do a lot of role play on physical exam nowadays for all of you. Like whoever in was in our course or not in our course doesn't matter. You have your own notes, right, of physical exam.
Mhm.
You need to just do a lot of role play. Now you guys know how to do it, because I just told you like how you teach the medical student what is anatomical landmark. So what is, you know, now that how to prepare. What you need to do, you need to do role play, and you have to just see that if you do this, then how much time I'm getting, or can I include some more information? So what you are doing at the moment, that you're trying to explain a lot to the medical student, because you don't have any idea how the time is going to be finished, right? Because we haven't done it previously. Now you will just try again and again with the role player, that if I give this information to the medical student, am I can I be able to finish this exam in 8 minutes? So if I can't, then what are the information I need to cut out? So that's how you will prepare. So you start doing role play with your partner, and then see that you have to give some information, like, because you are not doing it on the patient nowadays, you're just telling. Now explain should not take that much time, like what you need to get, like when you do physical exam on the patient, obviously explanation should be a little bit of less time taking. But if you explain a lot which is not needed, then the time will be up. So now we need to know that what we should include and what we should not. Because when we teach someone, we want to say everything, but we can't, because we have time restraint in here. Okay, so don't worry, Dr. Mokta, you will be fine. Let me discuss it, that what we can do here. Now, maybe I will include a lot of things. What you guys need to do, you need to just rule that out. You need to include something, exclude something. That's how you make your 8 minute time. Okay, but the important thing in this case is that you should be able to explain to the medical student the hand anatomy, which is a little different if you don't have basic idea. Dr. Mukta, you did great. You did all the important landmarks. You were going good, but the time was not with you. So in here, you have to explain the tendons here, what are the jobs of these tendons, what are the nerves supplying the hand, where exactly they are supplying, and what are the blood vessels that you are looking for. So in someone with a wrist cut injury like this at the flexor aspect, there can be injury to the three things: tendon, vessels, and the nerves. So we need to include all these three during our physical exam, that we rule that out. Okay, and the diagnosis will be also dependent on the findings. Now, you have to explain, or you have to remember all the name of the tendons, muscles, nerves, and everything, unfortunately. Okay, and that's hard, but it's not impossible. Okay, with practice it will be fine, and after today's session you guys will be pro in this exam. So let me show you how we are going to do that with a medical student. First of all, you are going to introduce with the medical student just like we did previously. So hi John, this is Arshan, one of the doctor here. It's very nice to meet you. How have you been so far? What medical year you are in, John? Doctor, I'm fourth year medical student. Oh, that's good. You must be really having a very good time. How you're feeling? Yes, doctor, I'm fine. So John, today we are going to do a physical examination. But before we do, I would just want to take a little permission from the patient so that he gives us the consent to talk it with you. Now, I have included that in here because this is a good thing. We can ask it before we give any information to the medical student. We can ask permission from the patient. Okay. Then you say, now the patient is happy with us. John, before we do any physical examination, the most important thing is we need to wash our hands properly. We need to introduce ourselves, and then we need to take permission about whatever examination we are going to do. In this particular patient, we have got a patient who is 30 years old male, came with a knife injury at the flexor aspect of the left wrist. Good thing is that the bleeding has been stopped with pressure. Okay, now someone having this sort of wrist cut injury, we need to do an extensive physical examination to look for any underlying injury to its tendon, vessels, or nerves. So we are going to just take permission from the patient that we are going to examine these things. And we need a good exposure of this hand also. Okay, once we are doing that, then we are ready to start the physical exam. Because this patient had a cut injury, it's always better to find out what is the stability of this patient, if this patient's vital is stable. So in just very quick, check the vitals like blood pressure, pulse, temperature, respiratory rate, and saturation. Because of the cut, he might be in a lot of pain, so it would be a good idea to arrange some painkiller for him, making sure he doesn't have any allergic condition. When we start examination, first start as a general appearance, that how does the patient looks like from outside. So you look for any obvious sign of distress, any obvious bleeding coming out from this wound. Okay. Then in this case, we will start with an inspection, palpation, which is mainly looking at the arm, feeling the arm, moving the arm, and checking all the injuries. So you start with the look. In the look, you mainly start with the palmar aspect first and then dorsal aspect. In the palmar aspect, as you can see, there is a longitudinal cut wound at the wrist, about 5 centimeters in size, no active bleeding. And you also look for any thinner or hypothinner bursting. And most important in this case is you look for the finger posture. In a normal patient who has intact tendon, when they keep the hand in rest at the table, the finger should be in a semi-flexed position. If they have any tendon injury, that semi-flexed finger posture will be lost. And you can have a very good idea just by looking at it. Okay, so that is very important. On the dorsal aspect, you just give a normal inspection, like look for any redness, any rash, any injury on that area, any sign of trauma. Don't bother too much with the dorsal aspect. Okay, it's not very important. Once you finished with your look, then you come to the feel. Before you touch the patient, again, ask the patient that you are going to do so that they are aware of that you are going to touch it. Because if you just touch the patient without prior knowledge, they can feel more pain and they will not be prepared. Okay, John, do you understand? Yes, doctor. First, start checking the temperature. So check the temperature with the dorsal of your hand. First, check it with the normal hand and then check it with the abnormal one. Check for any cool periphery, because if there is any vascular abnormality, the periphery will be cool. Check at the pulse, especially radial pulse. But if you look at this picture, this patient, if you want to check radial pulse, you might elicit tenderness. So don't bother. Go up, check the brachial pulse. Don't say, guys, in here that you want to check pulse in the other hand. No need, because why? Checking pulse in the other hand will not help, because other hand doesn't have any cut. Okay, so don't say that you are checking pulse in the other hand. Then to check the circulation, we need to check the capillary refilling time. To check that, apply a gentle pressure on the nail bed of the patient for about 5 seconds and then release. In a normal person, that initial pallor should get back to its normal color in less than 2 seconds. If you see that capillary refilling time is normal, pulse is normal, you can rule out any vascular or any vessels injury. Clear, John? Yes, doctor. So now that we have cleared, or now that we have ruled out any vascular damage, we move to checking for any tendon injury and nerve injury. That part we do by checking the movement. Now let me just give you what are the movement we are going to do in this patient. In hand, you do wrist movement, which is flexion and extension. So you show it by your hand that how you are doing flexion and extension. So wrist flexion is done by this, wrist extension is this. If you have time, you can also say that when you want to do a wrist extension, you ask the patient to touch the palmar aspect of their both hand and do like this, and then touch the back of their hand and then flex their wrist like this. So you can say in that way if you have time. If you don't have time, just show it with your hand and then move on. Once you finish with the wrist movement, go to the finger movement. In finger, we have finger flexion, extension, abduction, and adduction. For that, you ask the patient to make a fist, that's flexion, then open the fist, that extension. Ask the patient to spread the finger, that abduction, close in, that adduction. Okay, show it with your hand. What is finger flexion, extension, abduction, adduction? The next movement is taking the thumb. Thumb has 5 movements: flexion, extension, abduction, adduction, and opposition. So when you do this, you just show it to the medical student how to do that. So these are the 5 movements of thumb. This is thumb flexion. So you move your thumb across the palm and then you move away from the palm, that's extension. In opposition, you touch the thumb with the little finger. In adduction, you bring your thumb closer to the index finger and then move away from the index finger, that's abduction. So in a very simple array, flexion, extension, opposition, adduction, abduction. Now, what you have done, you explained that you are going to check wrist movement, finger movement, and thumb movement. Now, guys, take time in here because this is the most important part and they're going to fail or pass you based on this, because this is where you talk about anatomical landmark. So, John, because this patient has the injury to the flexor aspect of the wrist, in here, in the flexor surface of the wrist, we have 2 tendons which flex the wrist, which we call flexor carpi radialis and flexor carpi ulnaris. Look at these 2. Flexor carpi ulnaris and flexor carpi radialis. These two actually flex the wrist. Okay, so if the patient has tendon injury, then patient will be unable to do the wrist flexion. So just explain it to the patient. So you say that, John, your wrist flexion is done by two tendons. One is flexor carpi radialis and flexor carpi ulnaris. You can show it because you know that flexor carpi ulnaris means in the ulnar side or medial side, and radialis means radial side. You can just show it. You don't need to explain everything because you can't. Then come to the finger. In finger, your flexion of the finger, when you ask the patient to make a fist, patient needs to use flexor digitorum superficialis and flexor digitorum profundus for flexion. Now this part is a little confusing and you will get confused. Let me explain it. So that's your finger flexion. Finger flexion is done by flexor digitorum superficialis, flexor digitorum profundus. It's very easy. Flexor means it causes flexion. Digitorum means digit, which means finger. Superficialis, it mainly superficial. Okay, so flexor digitorum superficialis. So which tendon or which muscle flex the finger? Flexor digitorum. Then we have flexor digitorum superficialis and profundus. Profundus is a long muscle. It has 4 tendons and it gives supply to all your second, third, fourth, and fifth finger. Okay, so if you look at here, so that's your flexor digitorum superficialis. Flexor digitorum superficial tendon only helps with flexion of your proximal interphalangeal joint. Not this one. This one. Okay, proximal interphalangeal joint. The flexion of your proximal interphalangeal joint will be done by flexor digitorum superficialis, and the distal interphalangeal joint flexion will be done by flexor digitorum profundus. Now, problem in here that flexor digitorum profundus also helps with flexion of the PIP joint. That means PIP joint is getting supply from FDP and FDS both, and FDS only supplying PIP. Now, the problem happens that if a patient is able to flex the proximal interphalangeal joint, you don't know which muscle is helping. Is it superficialis or profundus? Because both gives the supply. To differentiate between these two, we need to do a maneuver. And that's the main part in the exam that you have to explain about it. Okay, so if you want to differentiate between FDP and FDS injury, what you need to do, you ask the patient to put their hand on the table flat with the palmar aspect on the above. You hold down flat all the fingers but one. So what you do, you restrict all the fingers, but you just let the patient move one finger. Once you do that, if you hold down all the fingers, what you are doing, that you are actually restraining the action of FDP. Why? Because FDP acts as a mass action muscle. What does it mean? So this is FDP, flexor digitorum profundus muscle. These are the tendons. It gives 4 tendons. If you restrict these tendons, what happens is that patient's FDP will be restricted because it is a mass action muscle. If you restrict 3 fingers, you restrict the full FDP. Okay, so that's why what you need to do, you hold down flat all the fingers but one. Then ask the patient to flex the PIP joint. When you are restraining the other finger, you are actually restraining the movement of FDP. That means FDP is no longer helping with the PIP joint flexion. Only FDS is helping with the PIP joint flexion. That's how you can differentiate between the injury of FDS and FDP. I know this is hard, right? Okay. Do you guys understand a little bit of it? This is how we are going to do that. Look at this picture. What you are doing, ask the patient to keep the hand in flat with the palmar aspect above, and then you hold down all the fingers but this one. Then you ask the patient to flex the PIP joint. If the patient is able to flex it, that means only muscle or tendon which is acting is the flexor digitorum superficialis, because the FDP is restrained by your holding down the other fingers. Clear, guys? Good. If you are clear about this one, this is the hardest one, mainly. So you have to explain this thing to the medical student, that how we are going to do that in a very simple way. All right. So let's start again with this movement, how we are going to explain it to the medical student. All right, because now you know that what are the things that we are looking for. Let me just explain the thumb movement, then I think it will be better idea. So your finger flexion and extension will be fine because extension done by radial nerve, so it will be intact. Finger flexion will be impaired because both FDS and FDB can be damaged. Then abduction and adduction of the finger is given by interosseous muscle. Okay, this interosseous muscle is supplied by ulnar nerve. Then come to the thumb. In the thumb, we have 5 movement. Remember, flexion of the thumb is given by FPL, which is the flexor pollicis longus. Pollicis means thumb, okay? And flexor means it flexes. So which one flex? Thumb, flexor pollicis longus. So finger flexion will be given by flexor pollicis longus. That means the thumb flexion. Thumb abduction will be given by abductor pollicis brevis. Adduction given by adductor pollicis. Opposition is mainly both median and ulnar nerve helps with the opposition. It's the action of the whole muscles of the hand, like interosseous, lumbricals, all the things. So in here, you need to know what muscles are supplying what movement and what now also their nerve supply. Okay, so it's a little tough, but you have to explain it because examiner will mark you based on this landmark that you're talking about. Okay, so it's a good idea to show the nerve sensation to the medical student first. Like you can start that. First thing that we are going to do is to check the movement. In the movement of the hand, we are looking for any tendon injury and we are looking for any nerve injury. Let me just show you the nerve sensation of the hand. Your hand, the palmar aspect is supplied by median and ulnar nerve. Median nerve supplies the thumb, index, middle, and half of the ring finger, and ulnar nerve gives supply to the wrist. Okay, now patient knows that medical student knows that the hand is supplied by mainly median and ulnar nerve in the palmar aspect. Okay, and then you can introduce the nerve supply of this muscle during your explanation. So let's explain all this thing in one go. So you will say, so we finished with the capillary refilling time, right, in the field. Then we are starting explaining the movement. So John, now we are going to start the movement of the hand. This will help us to find out if there is any injury to the tendon or to the nerve underlying the injury. For that, first of all, we need to know the nerve supply of your hand. Your hand is supplied in the palmar aspect by the median and ulnar nerve. Median nerve supplies your thumb, index, middle, and half of the ring fingers, and the rest of it is supplied by the ulnar nerve. Is this clear, John? Yes, doctor. Now, let's start with the wrist flexion. Your flexion of the wrist is given by two tendon known as flexor carpi radialis and flexor carpi ulnaris. Now, if the injury of the patient damages this tendon, then patient will be unable to do the wrist flexion. Come to the finger. Finger flexion is done by flexor digitorum superficialis, which mainly helps with proximal interphalangeal joint flexion. That is also supplied by ulnar nerve. Your finger flexion also given by flexor digitorum profundus, which mainly helps with distal interphalangeal joint flexion. Also, it helps with PIP joint flexion. This muscle is actually supplied by both median and ulnar nerve. Are you with me so far? Yes, doctor. Now, what happens, John, in here that because your proximal interphalangeal joint is supplied by both FDS and FDP, we need to differentiate that which one is actually damaged. To differentiate between that, you ask the patient to keep the hand on the table. You hold flat all the fingers but one. You let the patient to flex the interphalangeal joint of that remaining finger. If the patient is able to do that, that means only the FDS is acting, and that means FDS is intact. I will discuss it in detail with you with more figures and actions. Is that all right with you, John? Yes, doctor. Also, finger abduction and adduction can be lost if patient's ulnar nerve is injured because ulnar nerve gives supply to the interosseous muscle. Come to the thumb. In the thumb flexion is given by flexor pollicis longus, which is also supplied by ulnar nerve. So if ulnar nerve is damaged, it will be weak. Same with the abduction of the thumb given by abductor pollicis brevis, which is supplied by median nerve. Adduction supplied by ulnar nerve, which supplies the adductor pollicis muscle. And also your opposition is given by both median and ulnar nerve. So first thing that we need to know that this nerve supply to each of these muscles and tendon, and depending on the finding that we get, we'll be able to know that which tendon and which nerve has been injured. So in here, don't bother with too much explanation. Just say, okay? Just say that these are the findings, because there is no way anyone will understand with the first time. Okay, medical student will also just look at you. That's normal. We also looked at when we were medical student. So that's fine. You just explain. Lastly, you come to the sensation and power. So in here, we'll also check the sensation of the hand for any nerve injury. So with the cotton wool and pinprick, you will look into mainly index finger for median nerve, little finger for ulnar nerve, and anatomical snap box for radial nerve. Most likely, this patient, if can have a median and ulnar nerve injury, then you will have loss of sensation in the whole palmar aspect. Okay, now maybe you'll not have enough time to discuss how to check sensation. Don't bother with that. Just explain that with the cotton wool, you are going to do that. Lastly, just talk about two things. That means the power. In here, even if you don't check C8 T1 power, that's fine. They're not going to bother with that. But you have to do these two things. One is Pentas test, another is card test or Froment sign. Pentas test look for median nerve injury. Froment sign look for ulnar nerve injury. Let me show you how to do this pen touch so that you can explain it to the medical student.
This is the pen test, which we will try to see the abductor pollicis brevis function.
So, you know, the median nerve gives abductor pollicis brevis, and that helps with the abduction of the thumb. You check this abduction of the thumb by doing this pen test. In Pentas test, you keep a pen at perpendicular to the patient's thumb. Ask the patient to move their thumb up to the ceiling and touch this pen. If a patient is able to touch the pen, that means their abductor pollicis brevis is working. Okay, that means median nerve is working.
The patient is asked to touch the tip of the pen with the tip of his thumb. नीचे ले एक और कर touch कर. This is the pen test.
Okay, so that's your pen test. So in here, you will say that we check two spatial power for median nerve and ulnar nerve. One is Pentas test, when we ask the patient to move their thumb up to the ceiling and touch the pen. If a patient is able to do that, that means their abductor pollicis brevis is working. That means their median nerve is intact. And lastly, we will check their ulnar nerve function by doing another special test called Froment sign or card test. In here, mainly you ask the patient to hold the card or hold the paper in between his thumb and index finger using the both. Okay, you can actually ask the patient to use their both hand. Once the patient's paper is in between their thumb and index finger, you pull the paper. Now remember, examiner hand also will be the same position. That means you have to hold the paper in your index and in between your index and thumb. So same position, and then you try to pull the paper out of the patient hand. If you are able to do that, that means patient's ulnar nerve is not working. Okay, because most of the small muscle of the hand helps in this like this adduction. See that this actually this we are actually checking the adduction of the thumb, which is the adductor pollicis, which is given by ulnar nerve. So to check that, you say that put this paper in between your thumb and index finger. I will also do that, and I will try to pull it. Please don't let me do it. Now, if you are able to pull it out, or during the process, if patient's DIP joint flexes, that means patient has low power. Okay, so that's how we actually check the ulnar nerve function. So let's see that patients. Now this one is called, see the DIP joint is flexed. Normal person should not have their DIP joint flexed. So this is the normal one. Okay. Now look at here. See, there is DIP flexion, and also you can easily slip out the paper. So that's actually called Froment sign or card test. Yes, these two tests you have to explain to the medical student in a very simple way. Okay, very simple. So pen touch, you can say in Pentas test, we are looking for function of the median nerve. So we ask the patient to move their thumb to the ceiling and touch the pen. If a patient is able to do that, their median nerve is intact. To check the ulnar nerve, we do Froment sign. So we ask the patient to put a paper in between their thumb and index finger, and we try to pull the paper out. If we are able to do that, that means patient's adductor pollicis is not working. That means ulnar nerve is not working. How many seconds I took? 30 seconds or not even 30 seconds. So this is how you have to explain. Okay, so that's how we finish this case. And lastly, the diagnosis will be severe deep knife wound of the wrist, severing all flexor tendon of the wrist and hand. Now, the thing is in the exam, because previously we would get the findings and we could diagnose this case. In here, most likely they would not ask you the diagnosis because they will not give you any findings. So maybe they will just ask you to show the physical examination in the whole 8-minute time. Or if they say, then you have to just say that this is a case of deep knife wound of the wrist, which could sever all flexor tendon of the wrist and hand, and also it could sever median nerve and ulnar nerve, and there is a risk that there could be injury to the underlying radial and ulnar arteries. So you just say could. That's your diagnosis because you don't get any findings. So in a nutshell, in here, this is one of the toughest physical exam. Remember, so you have to be very careful about what you understand, and your basics should be totally clear about this wrist flexors, nerve sensation, and everything. I've given like all the findings in here. If you just take help from this slide and from what I have said, you should be fine. So you start with the general introduction, look, feel. Now remember, in look, feel, don't take a lot of time. That's how you manage time. Okay, in introduction in here, don't take too much time. Just finish it within 2 minutes, this thing, and then keep 6 minutes for the next part. So in the movement, you first show the medical student what are the movement of wrist, finger, and thumb. Then you say that then these are the nerve supply of the hand. Show the median and ulnar nerve sensation. Then you start with one by one. So what is the wrist flexors? Flexor carpi radialis, flexor carpi ulnaris. If tendon is injured, then wrist flexion will be lost. Go to the finger flexion, discuss about flexor digitorum superficialis, which supply the PIP joint, flexor digitorum profundus, which supply both PIP and DIP joint. To differentiate between these two, we do that maneuver. Also, finger abduction adduction is given by interosseous muscle, which is supplied by ulnar nerve, that can be also lost. In the thumb movement, discuss about all flexion, extension, abduction, adduction, and opposition. Extension will be intact in here because it's done by radial nerve. All other flexion, abduction, adduction, opposition can be lost. And then you just touch the sensation part and the power part. In the power, if you don't have time, don't bother with the C8T1. Just discuss pen touch and Froment sign. Okay. And then finish your explanation. Okay, I'm so tired now. So how are you feeling, guys? Do you guys at least understand this case? Will you be able to do role play with your partner now? So will you have to check each finger? Now in here, you just talk. So you just explain. You are not checking anything. You are just explaining everything that you're going to do, Dr. Gina. So just touch it. You can't do each and everything because we don't have that much time. Yes, Dr. Batul, very good. So flexion of the wrist is mainly due to tendon injury. Flexion of the finger and thumb, that's actually combination of tendon and nerve, both. Okay. Then adduction, abduction of the finger is mainly because of nerve. Yes, because interosseous muscle is given by ulnar nerve. And thumb abduction is medial nerve injury. That's right. Okay. But mainly only tendon injury is mainly for wrist. Others are a mixture of nerve and tendon injury. Okay. Yes, Dr. Joy, the previous student will be joining our new P classes. That's all right. I will do that. Dr. Francie, in Anatomical Landmark, they are looking for mainly that if you are able to show to the medical student that some of the anatomical landmarks you have to touch. Like in this case, what are the anatomical landmark we are looking for? You have to talk about all these ulnar nerve, median nerve, all the wrist flexors, abductor, adductor. So that's anatomical landmark. When you are talking about muscles, tendons, nerves, these are anatomy, right? So you have to talk about this. That's exactly what is meant by anatomical landmark. Like in the hematological P we discussed today, your anatomical landmark should include at least epitrochlear lymph node. How you are checking the pallor icterus, you can include that. Then where you are actually checking the sternal tenderness, where you are checking the neck lymph nodes, axillary lymph nodes, inguinal lymph nodes. These are all anatomical landmarks. You may not be able to touch everything, but at least try to touch most of it. Like if you have time, just explain where you are looking for it. No, Dr. Najia, examiner will not talk to you. That's why I haven't talked to you. It was very rude of me because you have been asking the vitals, but I could not. That's I wanted to show you what will happen if you do that. Yes, your pen touch and Froment sign will help you to exactly define if there is any nerve injury. That's why we are doing it, right? So pen touch will give us median nerve injury, Froment will give us ulnar nerve injury. And if we get this positive, that means obviously nerve is injured. Examiner will not talk to you at any case, Dr. Najia. No case examiner is talking to you. Maybe they will start talking sometime later on, but not until now. So in here, diagnosis, you just give to, like in other cases, you will get PFE findings. Like that's how you give diagnosis. Also in the history, you will get some positive finding. That's how you give diagnosis. In physical exam, they're not asking you, like they will not fail you for diagnosis mainly. They will mainly assess you on how you're doing physical exam. And based on the stem and whatever you find, give the most likely diagnosis and give a lot of differentials. That should cover. Dr. Joey, the new physical examination classes, because we take physical exam after 2 months, we just started the new batch. So it should happen in 2 months' time. And you'll get some announcement in the Facebook group. We don't have any physical examination course. It's just only for the course students. Actually, I don't have much time. If I would have some time, then I would be happy to take that. Because I'm taking this class, you guys, I have to take another class at night. And that's really so hard. So much time consuming. Yeah, previous students will be able to take our physical examination class. For the new batch students, we will do the P in the next 2 months' time. All right, guys. So I hope it was a little helpful for your preparation. Many of you are from our course, but many of you are not. If you guys still want to join the new batch, still I think we closed the admission on 21st of March, but if you missed somehow, but if you want to join, is it still possible? Just give us a message in the messenger or email us. We'll be able to help you. Okay, so we'll finish it here tonight. Thank you so much for joining it. And I'll be happy to get any feedback from you, like how did you enjoy this class, or do you need anything else, or whatever you, where exactly you're feeling the problem. Okay. Thank you. Have a good day. Bye.